evaluator. That's the responsibility of your training programs. Take you through that, make sure you're familiar with the equipment, make sure you're familiar with the evaluation tools we use, and actually witness you evaluate some before they turn you loose, because this is pretty high stakes. You're helping us make a decision whether we are or are not going to certify somebody. So you may be turning them loose on the streets, or you may be preventing them from functioning and working if we hold a certification because of the evaluation. And we'll kind of hit on that more than once tonight also. So I'm going to talk a little bit about kind of the philosophy of psychomotor evaluation, because it is much different than what most evaluation is, a lot of what we do in the classroom. So the challenges of educating somebody to do skills is we need them to perform basic aspects of the skills, all the same. There is a certain way to do some things, or at least a general plan of how to do skills. And to be fair to the students, if we're going to evaluate them, everybody needs to be on the same page with that, which means the instructors need to know what the evaluation tools are and what students need to be taught. The students need to know what they have to learn and how they need to do it. And the evaluators need to know what they're going to use to evaluate those students. So everybody kind of needs to be on the same page. And we'll go to the National Registry website here later and look at some of the evaluation stuff that's available to them, or available on the website there. But the registry doesn't hide anything. We use the National Registry as a certification exam, and they don't hide anything. It's no surprise when somebody walks in on what the evaluation is going to be. Everything is pretty much spelled out step by step, and most students have been drilled on it pretty heavily step by step before they ever show up. What we also hope is that the evaluation is a direct reflection of both the education the students received and also what we do in the field. We're going to talk about some changes coming up with the National Registry exam for the paramedic level. It's even going to make it more like that. But that really is what we're trying to do, is evaluate what skills are being used, how often they're being used, what are important for us to know, and that's where the evaluation comes from. Now, the advantages of doing a psychomotor exam are huge. We can approximate job performance, get an idea of how people work, and even what their leadership skills are, which I'll talk about here later when we talk about the new test that's coming up. But we can put them in some sort of real-ish life experience. I'm not going to say it's exactly like real life, but real-ish life experience, and evaluate how they do it, how they do the skills, how they run a call even. Disadvantages of this are huge, though. It's really hard to standardize. And this will be another thing I beat on quite a bit tonight, is the standardization, how we're trying to make everybody have a standard examination process. And if you've never been involved with the test before, it is very time-consuming, and it costs a lot of money, and it's labor-intensive, and it takes a lot of equipment. It's not easy to do. In a way, we've been really lucky in EMS is that we've done this from the very beginning, so we're used to it. We have this very well established. There are other allied health professions who have not started off with a practical exam and have struggled trying to figure out how they could offer one or require one for certification. So as much as we complain about it, we're actually ahead of a lot of other places by doing it. So there's different groups that have different responsibilities in this whole training evaluation process. The training programs have a responsibility to train students, have them ready to go. When the student completes the class, essentially the training program is verifying they are entry-level competent, and that's what the test is designed to test, is entry-level competency. So in theory, when they get done with class, the training program is given a stamp of approval and saying they're good to go. They're ready to be an entry-level competent EMS provider. So part of that responsibility is documenting mastery of each skill. Now, I say mastery of each skill in the training program, but you notice we don't test every skill in the evaluation, in the certification exam. Part of the reason is there are some things that are very seldom ever done. We don't evaluate retrograde intubation for the paramedic because most people go their entire profession, never do it, and a lot of services don't utilize that skill. What we try to do are the high-frequency skills that have a risk. So we want to make sure people can do the skills they're going to do a lot and can do them well, and especially ones that may be risky to the patient. We want to evaluate those students before they go out and do those, and that's the reason the practical exam does the skills it uses, and not every single skill we may have to come across as an EMS provider. Also, the responsibility of the training program is to use qualified evaluators during certification testing. A lot of the training programs set up these tests for the certification exam, so they do have to have evaluators that not only have the endorsement that the training program has determined they are capable of doing this job and have the tools and the knowledge to do well. Now, during the class, we have no requirement anybody has an evaluator endorsement. For the state anyway, some of the training programs do require that of their staff. You need to be a trained evaluator to evaluate for them also. But for the certification exam is the only part the state gets involved with. Now, one thing we should be aware of, and I'm going to beat this a lot, is this conflict of interest. It's another thing the training program needs to evaluate when they pick their evaluators, and I'm going to talk about it as a responsibility of the evaluator also. But the training program needs to pick people that do not have a conflict of interest with the students. Specifically, we can't have instructors evaluate for students if they've taught. Now, there are some caveats there. If you're an occasional instructor, or maybe you were limited to one specific part of the course content, in that case, you may evaluate something. Let's say you taught PHTLS and you only did PHTLS one weekend. They may pull you in as the medical assessment evaluator for that station. That's probably okay, as long as you're comfortable with it as an evaluator and the training program's cool with it. That would meet the letter and say, yeah, that's all right to do. But if you were the PHTLS instructor, the last station you should be evaluating is anything have to do with the trauma skills. Then there's also the personal and professional relationships, and I know in some areas that gets really difficult because we're a small community and we know everybody. Even within the state, everybody seems to know everybody in EMS. So sometimes that can be really difficult, and that's a personal call a lot of times of how you feel about it. I'm going to bring this up again, and we're going to hammer into this a little bit more later on. So when the training programs are picking evaluators, the things they need to be looking for is that you are an endorsed evaluator, which means some training program has picked you to be an evaluator, has told you to get to an evaluator workshop. You have to be certified to perform the skills you're evaluating. So an EMT cannot evaluate intubation unless they're also a respiratory therapist. We would probably allow that. But you have to have that skill in your scope of practice somewhere and in some fashion to evaluate it. That just makes sense that you want somebody who knows how to do the thing, evaluating whether you know how to do it. And then they must be knowledgeable in the skill, equipment, and procedure. And again, that's the responsibility of the training program. Is anybody they pick as an evaluator knows how to evaluate that station and do that. Haven't covered much yet, but I just do want to pause in case there's any questions. If you got a mic, go ahead and use that. Otherwise, I'm watching the chat window also. So if there's a question pops up in there, I will try to address it. And for those who have my cell phone number, go ahead and text if you need to, because I've got that in front of me also trying to pay attention to it. So it's quiet. I'm going to assume there's no questions yet. We really haven't dived into much at this point. So let's talk about the examination. So the examination, what we're trying to do is verify candidates' hands-on abilities and knowledge, have them do the things we need them to do, and evaluate whether they actually do it right. This is really important to realize. The next step, though, this is not a teaching, coaching, or remedial session. Remember, I said when the training program gives their stamp of approval and say this student is done with class, we deem them to be entry-level competent. We don't even call that person a student anymore. In rule, we start to call them a candidate at that time. They're a candidate to be an EMS provider. So their time to figure out what they may not be doing right is done. That should have all been figured out while they were still in the training program. So people get really upset at the practical examination when we don't tell them what they did wrong. We'll just give them a pass or fail. And they want to know, well, they're so used to getting feedback, which is appropriate in the classroom time, they want that feedback on the practical exam, and they're not going to get it. And as an evaluator, you can't give that to them. You're not to be telling people, here's what you messed up, so next time you can fix it. They should have had that all pretty well hammered out before they ever came in to do this test for the certification exam. I talked about this also a little bit too, about why we pick the skills we do. Is skills are based on the day-to-day out-of-hospital care and the potential of harm. So again, something we do very infrequently, we're not going to test, because the service themselves are going to need to have something in place to make sure people know how to do that when that time comes to do that once in a career maneuver. We're really focused on the things we're going to use on a more frequent basis, the intubations, the starting IVs, the pushing medications, the performing assessments, and those type of things. And then some, like intubation, we don't do that frequently, but there's a great potential of harm if we do it incorrectly. So the training program has chosen you for their ability to provide a fair, unbiased, objective-based evaluation for everyone. And I almost don't even like to use the term evaluator. I really like the term observer, because that's really what you're going to do, is you're going to observe the individual and document what they do. And I'm hitting this again, like I told you, you need to really be aware of any conflict of interest. And we don't want to put you in a position of conflict of interest two different ways. We don't want anybody to think that you passed somebody because you had some sort of relationship with them, or wanted to develop some sort of relationship with them. Likewise, we don't want anybody to think you failed them because you had bad feelings about them in some way. And that's one of the reasons we don't want instructors to evaluate what they taught. They've seen the students over a period of time, and if they're having problems, that student shouldn't be in the position to be testing now. So we don't want what happened in class to waive an individual's evaluation, because we want that, again, to be fair and objective. You don't want to get yourself in a position, because, again, you could potentially be preventing somebody from working because of this. They may lose a job if they don't pass this test, or lose a position they have. You don't want anyone to come back and say you were unfair to us or unfair to them. So to be your qualifications instructor, you need to be, or an evaluator, you need to be licensed at the equivalent level or certified, depending on what phrase you want to use. The registry does have some specific criteria for certain skills, such as the patient assessment trauma. They want an ATLS, PHTLS, or ITLS instructor recommended. Patient assessment medical, they would really like to have somebody with ALMS that's completed the ALMS course to do that one, because again, it's a medical assessment. Ventilatory management, they like to have an ACLS instructor in there. Cardiac management, both static and dynamic, they do have to have an ACLS instructor. Cardiac management AED, they have to have a BLS instructor. And then for pediatric skills, they like to have a PALS instructor recommended, but there's also a lot of other pediatric courses out there now that didn't exist years ago. We have the PEP and the PPC that's also available. So if you have somebody, though, who's familiar with pediatrics, and has had some experience with the evaluation of pediatrics and working with the skills. So like I said, as an evaluator, you observe the candidate's performance. You're not even going to have you don't even know what the criteria is for pass or fail. We don't want to put you in that position. You're making a decision where somebody passes or fails. We just want you to evaluate the station, observe it, document it, and then there's a magic decoder ring that the proctor will use to determine whether it was a pass or fail. Now, some people you're going to know because it's not pretty, and you're going to have lots of check marks and critical criteria. You can probably figure out they're not going to pass that, but we're trying not to put you in the position. You're not making a determination of pass or fail. You are just purely documenting a performance. Somebody else is making the pass or fail decision. As evaluator, also, you can only evaluate what's listed on the evaluation form. And why I'm going to tell you this is important, because I've seen this done. I had a test several years ago where I found out about halfway through the test that the evaluator was going off script in the airway station and asking people questions like, well, if you give them 4 liters by nasal cannula, what percentage of oxygen are you delivering? And it was just throwing the students for a loop because they weren't prepared for that. They hadn't trained that way. They hadn't been told to prepare for questions. I had to stop the station, go in and talk to the evaluator, and asked him why he was doing that, because it wasn't anywhere in what's written in your evaluator materials. He just thought it was important they know that, and he was trying to help them out. And it didn't. It had the exact opposite effect. It just totally freaks the candidates out. So you need to evaluate. Only listen to the evaluation form. You don't go off script. You don't use your own personal, what you think is important to learn. These evaluation tools have been vetted through multiple layers to come up and be set the way they are for a reason. And also, as evaluator, you are responsible for completion of documentation. Consider them to be like a patient care report. They could be subpoenaed. I've actually had to use them for investigations a couple times and get the entire class roster, class test sheets from the National Registry for either investigations into evaluators or investigations into, did this person really pass and did they know what they were doing. So treat them just like a patient care report. Make sure they're complete. Don't leave blanks. If you make a mistake, one line through it and initial it. These are essentially a PCR. So when you're at the site, if you do have questions about whether something's appropriate or not appropriate, or how you should be evaluating something or marking it, there's going to be a couple people floating around. Now for a EMR and EMT exam, those are put on and proctored by the training program. Usually your training program director is going to be the proctor. They have access to the medical director if need be, and they will work together and make determinations if they need to know that or need to do that. For the AEMT and the paramedic exam, there's going to be a National Registry rep. This is an individual trained by the National Registry. We have, 4 or 5 of them in the state right now that can do testing in the state of Iowa. They're going to be there on site. They're going to have a medical director. They're going to have a phone-a-friend phone number at the National Registry if a question comes up. If something comes up and someone just doesn't know, is this appropriate? Can we do it? Should we be doing it this way? They'll get that figured out. Now do remember, this is a National Registry exam, so it doesn't have to do with your personal way you do it at your service. This is what is set by the manufacturers, what's common practice. I think probably the best example I have of this is the KED board, because people freak out about KED boards being put on a certain way. They like the straps put on in a certain order. They want them cinched up at certain times. And really, if you read the manufacturer's instructions for the KED board, the only thing it says is you need to immobilize the body before you immobilize the head. So it doesn't have to be middle, let's see, my baby, I always have to think through it. It doesn't have to be middle, bottom, legs, chest strap, then head. It's just got to be body, then head. So we've had this issue a few times at tests I've done, that people aren't putting straps on the order of the evaluator. Sometimes I have to go in and re-educate the evaluator on that, saying this is appropriate. And then you're going to have a scenario for a lot of stations. You're not going to know that scenario until that day. In fact, the testing site doesn't know the scenario until that day for the advanced exams, when the proctor or when the National Registry rep shows up and gets ready to go. They have to be ready to do all 3 of the randoms. And at least that's how it used to be. I'm not sure they're still doing it that way, but you're not going to know it until showtime. So I've hit on this a little bit. Some of these things are really important for me, so I hit them over and over again. Good medical documentation. You're going to identify both good and poor performance. And then you're also going to document criteria. Now I'm going to pull up here in a little bit. We'll pull up one of the evaluation sheets and take a look at it. Once I figure out how to flip back to that from where I'm at. But there's going to be, well, maybe it's a good time to just do it right now. Let me pull this up. So I said, if you go to the National Register website, they have all this information on here, and they have all the skill sheets. I think one of the best ones to demonstrate this is patient assessment trauma. Let me make that a little bit bigger. So you see how this form works. You got the candidate name, you got a date, a scenario number, you're the examiner, your name needs to go in, and then you sign it when you're all done too, signifying everything's done and complete. All this, please, please, please make sure this is legible. Make sure you get the correct spelling of the candidate's name, because what's going on behind the scenes that you don't see is there is a room where the proctor is at, stacking up these sheets as they come in and comparing them to the pass-fail criteria. So once they get bogged down, if they can't read the name, don't know which one this belongs to, it starts to slow things down, and very quickly you can have that room just comes to its knees begging for mercy because things start to get so backed up. Because the proctor also has some other responsibilities. They also have to be going to every room. They're supposed to examine every preceptor or every evaluator at some point. So there's a lot of things they've got to do. Make sure you have this all legibly written down so they know first who they have coming in. If they do have questions, make sure your name's legible so they can track you down and find you. So on the form, you see it's really just a series of points. And either people get points or they don't get points. And you only do points in whole points. We'll bring that up again later too, because math gets hard. So takes or verbalizes body substance isolation precautions. That's purely a 1 or a 0. Either they did or they didn't. Determine the situation is safe, 1 or 0. You get into some then, like breathing. There's 4 points possible in breathing. So they get a point for each one of these. So they did the breathing, they did the ventilation, they did the oxygen, they did the check for injury. They get 4 points. They miss any of those, they get a less point for that. Now I want to go down here to the critical criteria. Because as you can figure, since they're critical, they're bad. Anytime you check a critical criteria, you need to document why you check the critical criteria. Now some seem so simple to us. Third, take a verbalized body substance isolation precautions. You click it, you check mark it, you need to document what it was. What didn't they do? They didn't talk about putting on gloves. You feel they should have had eye protection on, they weren't wearing the eye protection. Whatever it was, the reason for you checking that box needs to be documented on the back, because the proctor is going to go back and take a look at that and decide, yeah, that really does count, that's a problem, or, ooh, in this scenario, that really wasn't the issue. So they'll probably come talk to you about that, but they may disregard that critical criteria, and then they have the ability to do that. Now, one thing I'll tell you that will just drive the proctors nuts, if you give a point up here for body substance isolation, but then you check it down here as critical criteria for failing to take or verbalize body substance isolation, that's a problem. They're going to stop the station, discuss that with you, and again, kind of bring things to a standstill while they're doing that. So just make sure your documentation matches from top to bottom. Any questions on anything so far? Okay. So like I said before, the evaluator is not going to know if an individual has successfully completed their station. You don't have the actual pass-fail criteria. The site proctor will know and make that determination. The site proctor will notify the candidate. One of the things the proctor will ask the candidate before they give them results are if they feel they were discriminated against in the station or they had a problem with the equipment that led to a problem with their performance. They have to give that answer before they can get their results. And if they do say yes, there was a problem, that's going to be investigated before the individual can get the results and a determination made if there was something wrong done. But this is, again, it is all based on your evaluation and the documentation you provide on those sheets. So you may be working with some other people in your stations. Sometimes there's an assistant, sometimes there's a live patient, and they have some very specific roles to fill also. For the assistant, they need to be a certified provider because they're going to function as an EMS provider. They're considered to be the same level of certification as the person being evaluated, and they're competent. This is really important. Think back to when you went through the practical examination and how stressful it was. We're not trying to add additional stress. We're just trying to evaluate whether they have the tools to do the job. So having the assistant play games with them doesn't really evaluate how well they're performing. It's evaluating how well they can catch other people doing things wrong. And we're looking at entry-level competency, not a practice seasoned professional here. I actually have had a evaluator, this has been years and years and years ago, but an evaluator would give the assistant instructions to let go of C-spine just to see whether the candidate would catch it or not, and if the candidate didn't catch it, he would mark them as not maintaining C-spine the entire time. That's a fault of the assistant. They should be failing, not the candidate that's being tested. Likewise, the assistant cannot save somebody. The assistant shouldn't be jumping in and saying, hey, let me take care of this thing you forgot to do, and saving the candidate from making a mistake. You cannot use current students, so you can't have a student come in, do the scenario, then keep them to do the station as the assistant, and then keep rolling them that way. We're trying to limit exposure to the scenarios. And they're not needed for every station. When you get your materials, you'll find out whether you need an assistant or not. Now, the patient must also be an EMS person, and they're going to do some acting, so they're going to. That's why one EMS person knows a little bit about patients and how they respond. They do have to act the same with each candidate. We're trying to get a fair, objective, consistent evaluation. In theory, and I know this is a tough thing to carry through, but in theory, if I test in Burlington and have to go to Sioux City to retest, I should have the exact same type of examination experience. It shouldn't be something different from one place to another. Likewise, it shouldn't be a different situation from one candidate to another. Every candidate should have a similar experience when they come in to test. Both your patient and the assistants as the evaluator, feel free to use them. In some of these stations, there's a lot of things going on, and you may be documenting something, and you may miss that they actually palpated the leg. So your patient will probably know whether their leg got felt up or not. So ask them, did they feel your leg? If they did, you're good to go. But you're also the evaluator, so you're the one that gets to determine whether they did or did not. They can be a high-fidelity mannequin in some situations, and they do have to be of average height and weight, over 16 average height and weight. Because again, most of the scenarios, except for the pediatric station, all the scenarios are calibrated for the adult patient. I don't see any questions anywhere. We'll kind of talk about the different skill stations. We're going to talk about some of the equipment you need and some of the common issues we have with the skill stations. And also the tests themselves. I already mentioned the EMR and the EMT station are conducted by the training program for the Bureau. They use a state-approved practical, which is actually the National Registry test now, and the site proctor is identified by the training program, and often that's the training program director who functions at that level, functions as a proctor. So the EMR has 5 stations they need to do. They have a patient assessment, both trauma and medical, bag valve mask, oxygen administration by non-rebreather, and a cardiac arrest management AED station. So again, things that EMRs do quite a bit: assess patients, put on oxygen, and use an AED. Well, they probably don't use AED a whole lot, but it's an important skill. It's a high-impact skill. So the EMR, the emergency medical responder, has 2 full attempts to pass the exam. And this is where it gets a little confusing. You can retest within your first attempt as long as you fail less than 3 stations. So in this example I put here, the first attempt, the individual passed station A, they failed station B, they failed station C, then they passed D, F, G. They get the opportunity to retest. So they have first attempt, first retest is what you see on the second line. On that second retest, they passed C, but they failed B. Now they just need to retest station B. They have another retest. So on their third attempt, if they fail B again, they're going to fail the exam, they're going to document remedial training, and then they're going to take all the stations all over again for their second attempt. If they went in on that first attempt and failed 3 stations, they would have to document remediation and then come back in for their second attempt. Now, we allow people same day to do a retest. We don't let them get to do that third test or that second retest on the same day because that gets really high stakes. If they've made an error twice on the same station already, they probably need to go back, relook at what they're doing, hopefully go talk to their training program some and run through what they could potentially be doing wrong before they get that third one, because that third one becomes high stakes because after that they're going to repeat all the stations over again. Any questions on the retest thing? This gets a little tricky sometimes to follow through where people are in the cycle and where people are in the process. The more stations we get, the trickier it gets. I'm either doing a fantastic job explaining this or everybody is just dead out there. For those who don't know, I'm sitting in a very empty state office building right now just talking to myself, so I don't know if anybody's out there or not. I'm just lonely. Now for the EMT, they have a few more stations they're going to test. We're going to throw in spinal mobilization of supine patient, then a random skill. Otherwise, all the stations are pretty much the same as the EMR. Their random skill is going to be one of 4 stations, any of these 4. And how we're managing that right now is I tell the training programs we have a schedule and we change the random skill every week right now. Now the one thing with a random skill, if I come in one week and I failed long bone immobilization, and that's the station I failed, I'm going to have to retest long bone immobilization. We want to make sure somebody is actually able to do the station they failed. So if I come to test 2 weeks later, everybody else is taking bleeding control shock management, but when I tested 2 weeks before, I failed long bone immobilization, I'm going to have to test long bone immobilization again. Now the EMT, again, has 2 full attempts. They can retest up to 3 skills when making the full attempt. So if they fail 4 or more, then they would automatically have to do remedial training and then retest all the stations. So the EMT, they have 2 full attempts also, and I'll show you the stations here. And they can fail up to 4 stations to be eligible for a retest. They have 5, then they'll have to go and do the remedial training and retake everything. So when you look at these stations, a couple of these stations actually count as 2 stations. The IV and bolus medication are 2 separate stations. So if you establish the IV but then fail the bolus medication, you just have to retest the bolus medication. I don't know why I'm saying you. None of you are going to be testing this. You've already done it. But the candidate would have to retest bolus medication. Then there's also the pediatric IO and respiratory compromise. Those are actually 2 stations we often do together. You go in and do, the candidate goes in and does both of them. They do the pediatric IO and the pediatric respiratory compromise. Either one of those failed, they only have to retest the one they failed. And then there's random skills. One of these 3 will be a surprise to them that day when they start. Now the paramedics. A lot of the same type of things, have a few things different. typo, and I keep forgetting to change that. The cardiac arrest management, they have to do both a dynamic and a static. So dynamic is a live monitor to read, and the static is just a printed rhythm strip to read with the scenario. There's 2 oral stations which take the place of the medical assessment. Then the random skills also for the paramedic level. One of these 3. Now, if you've seen the National Registry's newsletter that came out, their winter newsletter, there was some information in there that the practical exam for the paramedic is going to change in fall of 2016. So now that we have all the training programs doing paramedic training, either nationally accredited or in the process of being nationally accredited, all 700 across the nation now have either been accredited or have a letter of review. The registry has decided, now that we have that, now that COA has got some oversight to all the training programs, we're going to start accepting some of the skills that the training programs check off, and they verify the competency. So we reduce the stations a little bit: patient assessment, trauma, and oral station, dynamic cardiology, static cardiology, and then there'll be another additional station, which would be an out-of-hospital scenario. It'll be either a pediatric, a geriatric, or an adult. Now, this has been a process that's been a long time in the making. Probably, I've been involved with this project a little bit with the National Registry myself, and actually got a chance to go observe one of the pilot tests that was done up in Minnesota a few years ago. The initial idea was we would do all evaluations by scenario, and we actually found out when we piloted it, it took a lot more time than the current stations, and it was actually costing a lot more money with all the staff they had to use to do the evaluation. So it kind of is right now geared down a little bit, and it will roll out in August of 2016 looking like this. So it means classes starting next year, well, even probably this fall, will be looking forward to teaching, being evaluated in this fashion. So in this out-of-hospital scenario, the candidate's going to have a trained paramedic partner to work with, and they're going to be evaluated on their way that they manage a call, how they team lead, how they communicate, direct the personnel and resources. It's really going to be looking at how does this individual run an ambulance call, which is kind of exciting. We kind of tried this several years ago with the EMT basic level, and what we were finding, we just really people weren't in the class long enough to really get the skills we were trying to evaluate in that. With somebody who's been through a paramedic class and an internship, they should be able to run a call by the time they come out of paramedic class. So we're going to actually evaluate that ability. I don't have much more information on this point, but if anyone has any questions on this new test, I will either try to answer it, or I know some people I can call to get answers if I have to. The one question had come up during the instructor workshop, or in the instructor update the other night, was what's going to happen with in fall of 16 if somebody starts the 12-station test and has to retest some of those stations when this new test starts. How are they going to handle that? And actually I had the chance to ask Gabe Romero that today from the registry, and he told me they'll continue to maintain the 12-station test until everybody who started that process is done with that process. So they're not going to have to change the way they test midstream if they fail a station. I'm sure Reg will be putting more information on all that as time comes up.
So there's a question here in Council Bluffs. If a paramedic graduates a paramedic program prior to this new test being implemented, can they wait to test under the new testing guidelines, or will they be required to test under the guidelines that were there when they finished the course?
That's a really good question. My assumption, this is just me assuming, and I shouldn't probably do this, but my assumption would be you'd be able, whenever you start testing will be when kind of kicks off, when you, let me try to word this correctly, when you start testing will affect which test you take, not specifically when you get done with class would be my guess.
Seems like
Because with the 2 years to test, originally we have a long time to track people, trying to figure out where are you in the process. And I didn't ask Gabe this today either, but as I'm talking, I'm kind of wondering if I fail my first attempt, I have to go to second attempt. Will I start over with all 12, or will I start over with just the new test? That's another question I think we need to clarify with the reg.
How do the new medical assessment stations differ from the oral station then? Is it more specific criteria that they're hitting?
Well, there's not for the new test. Are you saying, Sherry?
Correct.
Because there's not a patient assessment medical. They're going to keep the oral stations.
Okay. I meant the out-of-hospital scenario. I'm sorry.
Well, the out-of-hospital scenario will be a live scenario. You're going to have I think it's going to be a high-fidelity mannequin if one's available. You may have a patient to play with. It may have an acting patient. But it seemed to work pretty well when we did the high-fidelity mannequin. So it goes from assessing the patient, talking to the patient, picking them up, starting IVs. It's doing everything and coordinating the scene.
Okay. Thanks.
Yep. Pretty excited. When we did the pilot up in Minnesota, we actually tried to do it with a team of 3. You had a team leader and 2 assistants. And we had 2 evaluators, one watching the team leader and one watching both assistants. And everybody actually was evaluated. You got evaluated both on your ability to team lead and on your ability to be a partner. And wow, there was a lot of moving parts to that, and it was really hard to do. And we worked on that quite a bit, trying to get the bugs worked out of that, and it just didn't quite work out like I think it's a great idea, but it's hard. As a state, I was saying, show me I can give somebody a certification of practice based off this kind of crazy evaluation process, and they never really made the states comfortable with that, and they went to this single person, single with a partner, and I think I haven't seen how it works yet, but I think we're going to like that. Because remember, I have to hand out a certification of practice based off how people test, and so I'm really kind of picky about what does the test look like, what's the test testing, and I think I'm happy with this out-of-hospital scenario with a partner. Any other questions on that? Okay, now I want to get into stations a little bit, talk about kind of the goals and why we do some of these stations, and then talk about some common pitfalls with the stations also. So the patient assessment trauma, looking at the advanced tests for the AEMT and EMT paramedic, what we're trying to do with that is get them to look at a patient and figure out what needs to be done for that patient. Remember, these are practical examinations. We're trying to make them as real life as possible. So we give them a patient scenario. We have a patient that's moulaged. They should be assessing the patient, finding the issues, and then instigating the management for whatever issues they find. For the medical station, for the advanced EMT, their interviewing skills and then their ability to put that information together to figure out what is going on with the patient. Now, we don't do a medical for the paramedic because we have the oral station, which kind of serves the same purpose without being a scenario-based. So Sherry, I just got what you were asking. It took me a while to process. You're wondering why this psychomotor scenario versus a medical. You know, the medical station really a lot of times is just talking to the patient and then telling people, here's what I'm going to do. In the out of hospital scenario, they're going to have to actually do those things. So that's when they're going to start the IV, intubate, do the actual skills. in that scenario instead of just verbalizing a lot of what we do here with the medical. Our big issues with the trauma and medical, probably one of the biggest ones I've struggled with is proper moulage. We really want this to be as realistic as possible. We don't want to tell people, oh, when you look at the chest, you see this. They should be able to look at the chest and see the injury. They need to be moulaged and look like the scenario says they're going to look. Now, with the trauma, that also leads to appropriate clothing. I've had lots of issues with people coming in not realizing if they're going to be the trauma patient, that they're going to be disrobed. And coming in with undergarments, they're probably less than happy to be disrobed in. For the trauma patient, they have to visualize. They have to check the chest, check the abdomen, check the legs. So if you have someone come in and do that station as the patient, you really want to let them know wear like a bathing suit underneath it, something that you don't mind being seen in. And I got to be careful with that too, because there's some things people don't mind being seen in that other people may not want to be looking at. I should throw that out there too. And not in a bad way even, just the fact that it makes the candidate really nervous to see underwear sometimes if they're not expecting it. Had that happen. Also, because you're trying to get everybody the exact same testing experience, what you don't want to have is the very first person that goes in there that day has never seen this patient. This is all new to them, just like it should be. But the 10th person to go in now has seen the patient out getting a drink, going to the bathroom, has got a chance to check and, oh, notice that protruding bone in the arm. I better notice that when I go in there to do that. So you want to keep those patients covered up, try to limit their exposure to the candidate as much as possible. Some facilities have a really good way to do that. Some facilities a little more of a struggle. Both the trauma and medical stations are time dependent, so you need to document both start time and quit time. So you need to make sure there's either a watch or a clock. And then using the form as a rigid process. I want to bring that form back up again and kind of show you what I mean there. The form isn't necessarily I have to go from here to here to here to here to here to here, then down to here to here to here to here. It's set up to flow as probably most the scenarios will flow, but even here they have some asterisks. Where's the asterisk? Oh, there we go. And it even says if your areas noted by the asterisks may be integrated with sequence of primary surveys. So if they inspect the mouth and nose up here when they check the breathing and airway, you can accept that. They can get that point there if they verbalize and you visualize them inspecting the mouth and the nose. Up here, you give them point down here. It's not like you've done the 4 points here, now you need to do everything over again to get the 3 points here. So what we're trying to do is document all this, not necessarily say this is the steps everything has to be done in. Unless there's issues with critical criteria that says this needs to be done first. Ventilatory management. AEMTs will use some sort of supraglottic airway. Paramedics will do intubation and an alternative airway both. And there's no trying to guess of what you need to do in this scenario. The only thing we want to evaluate, can you put in a ventilatory assistant device in an apneic patient? So there's no like, oh, is the patient needing it? It's just you're going to go in there and you're going to do this. There's no evaluation of the patient really that goes along with it other than making sure you get it in right. The problems we run in this station is that when you get your information for the station, you can get a list of things you need in that station. Making sure that you have that is really important because, again, if I evaluate in Burlington this week and in 2 months go to Sioux City, the station I walk in should be identical for equipment. There shouldn't be anything new or different or missing from place to place. And that also means if there's things listed on there or there's things you have that aren't listed, you need to get rid of them because that is going to confuse people. They're going to start figuring, oh, I must need to use this because I've never seen it before. And it's amazing how candidates' minds work, but that's exactly how it works. I've never seen that before. It must be important. I've got to figure out how to use that now. You do need a watch in the ventilation because you need a time for delays, no longer than 30 seconds. There's a lot of discussion about what is an attempt, and the National Registry has identified an attempt at intubating as the laryngoscope being placed in the mouth. It's not anything to do with the tube itself going in the mouth. It's when the laryngoscope goes in its mouth. So if someone goes in, just takes a look around to get the anatomy down, then pulls out, that's an attempt. Now they only have 2 more attempts to actually get the tube into place. The reasoning for that from talking with the registry is that's when the trauma occurs, is by the hard blade more so than the plastic tube. Then make sure the equipment is prepared but not all hooked up before the station. They need to go through those processes of getting things correctly, and everybody needs to go through the same steps. So when the first person comes through and has to hook everything up from scratch, the next person should have to come through and also hook everything up from scratch. So making sure it's a consistent test time after time. I've been pretty consistent with saying things need to be consistent, and I'll continue to beat that around a lot. It's important to the certification process. Oral stations for the paramedic evaluates their ability to critically think and clinically manage the patient. This is a sit down and talk station. There's no hands-on really here. It's really just talking about, here's the scenario. What do you think is going on? What questions would you ask? Give us a differential diagnosis. Tell what the treatment plan is. Give a patient care report. Common issues with that is there's a divider you need to set up so the candidate can't read your scenarios. The scenarios are pretty elaborate. There's about 4 pages worth of material, so you're going to make sure you have some time to get yourself familiar with that scenario. The documentation actually recommends an hour before the test. You should be looking this over to get yourself familiar with it so you know what to respond, how to respond when different questions come instead of having to shuffle through paperwork to find what the response is going to be. You need to make sure there's scratch paper available for the candidate to use to take notes, but that scratch paper does not leave the testing scenario, then it's collected and destroyed when it's all done. You need to be careful about giving nonverbal clues. I would give you demonstrations of nonverbal clues, however I have no camera on my computer to do that. But often head nodding or shaking while the person's talking, you unconsciously do it when you're like, oh, that's a wrong answer, and you want to shake your head. You just need to make sure you play it cool and don't give any indications. One of the complaints we get a lot too is evaluators are aloof and not very friendly. It's like, yeah, because we told them to be aloof and not very friendly. You're not there to make a new friend. We're there to evaluate whether you can do the skills to lead you to getting a certification, do the job. And then you also need to do some role playing. It brings out your acting skills in the oral station because you're going to play the role of the patient, and they're going to ask questions about allergies and medical history and what happened, and you may have to play those roles. It's a fun station. I really enjoy doing this one. IV medications required for the advanced EMT and the EMT paramedic. Only thing we want to do, set up an IV, give a bolus. Not a lot of complexity to it. Common issues with IV and meds are some of them are the same as the airway station, making sure you have exactly what's on the equipment list. So everybody gets that same exposure and the same experience. You will have to play the patient some because they're going to have to ask for allergies before they give a bolus. Make sure you're not allergic to what they're about to give you. And then making sure you track time. They have a certain time limit to do both these stations. So I think it's been a while since I've done these, but I think it's 6 minutes to establish the IV. And I can't remember how many minutes they have to do the bolus, but you're going to need a watch so you can time that. Pediatric skills, the ability to do an airway and get an IO infusion in a kid. You can see the same thing here. Airway issues the same as the adult, making sure you have all the same equipment, making sure people, when they put the laryngoscope in the mouth, counts as an attempt. We don't use chicken legs in the National Registry exam. So I know a lot of people, I don't know if people are still using those much for training or not anyway, but there's some issues in disposing of them issues that registry doesn't want to have on their hands, and some making sure everybody washes their hands between stations, so you just use the mannequins. This is one station, the IO station is one station where you may jump in and stop somebody. It's probably the one station we have where somebody can actually injure themselves. I actually had this happen to me years ago when I was teaching at Mercy. A student comes in and stabilizes the tibia by putting the palm underneath the leg and starts to drive the needle into the tibia, which could potentially go into their palm also. That's the one time you may tell somebody, stop, you're not going any further, you're done here. That's, yeah, I think that's what one station somebody actually caused harm to themselves.
So do you want to talk just a smidgen about the pediatric IO, the statement, or the pediatric ventilatory, when it says that they have to, and I'm not looking at it, so I'm paraphrasing, initiate ventilations within 30 seconds of applying BSI?
Is that on this?
I think it's on the advanced EMT one, I know.
Let me look.
I think
It's on the evaluation tool, right? Sure.
yes, it is.
That's not what I'm looking for. Just saying, I got to find my right browser. I think I may have closed my browser when I was doing this. Nope, there it is. Okay. Pediatric respiratory compromise?
Yes, I'm sure it is.
Is that critical criteria?
Critical fail, yeah.
Let's see. Yep, failure to initiate ventilations within 30 seconds after taking body sepsis isolation precautions.
Yes. So we've had some conversations with the National Registry here, because to do all of that, you know, for teaching our students to put their gloves on walking into a station, or to do their BSI, there's no way they can get that done in 30 seconds. So with National Registry, what they told us was just to have our students not put their gloves on until they're ready to actually start the ventilations.
So,
So I don't know. It's been an issue over here, so I just thought I'd throw it out there.
okay, I'm just trying to think, if you go in, and here's how I used to teach it, you go in, you can start bagging right away. You don't even hook up to oxygen. It's just delivering ventilations. So you can begin ventilating. I mean, gloves on, ventilation starts as soon as you realize the patient's needs ventilations. And they're having problems doing that in 30 seconds?
Well, by the time they ask the questions that they need to ask, assess the breathing, get the SpO2.
I always taught it that you start ventilations before you start worrying about SpO2. Because you can start ventilations without oxygen as soon as you realize somebody needs ventilations.
Yeah, and there was.
And then get the pulse.
I think the SpO2 was the indicator that they needed. I don't remember what the scenario is that goes with this, but.
Yeah, maybe I need to see the scenario that goes with it. I'm just looking at it though, going, if I've identified somebody needs respiratory assist, I start doing that before I even got the oxygen hooked up, just to start ventilating them in the breathing and air, the breathing section if you find there's a problem. But yeah, that's the other way too, is, you know, you don't need to actually put on gloves until you start coming in contact with ugly stuff.
Yeah, so yeah, that's just been an issue. And I think it was the scenario that indicates, really nothing indicates respiratory failure until you look at the SpO2.
The SpO2, okay. Yeah, I haven't seen that scenario, so I can't speak too much to that one, I'm afraid.
Okay, that's fine. Thanks.
Oh, good question, though. So cardiac arrest AED for the EMT, then the static and dynamic stations I talked about. The ability to basically manage cardiac arrest for cardiac arrhythmia is what we're looking at here. Common issues: not doing the evaluation form correctly. That's probably the biggest thing, and since we got that, oh, come on, there we go. Let's look at that form, both the static and the cardiac or dynamic. So here's the static cardiology scenario or evaluation tool. And if you look at it, here's the big instructions. No points for treatment may be rewarded if the diagnosis is incorrect. And you only need to document incorrect responses and spaces provided. So when you evaluate this station, you're going to have 4 rhythm strips with the scenario attached to them. If they misdiagnose it, you write down what they did diagnose it as. If it's a misdiagnosed, it's going to be a 0 here, and no matter what they do with a misdiagnosed rhythm, it's going to be a 0 here. And the only thing you need to document underneath the treatment portion are things that were inappropriate, things they shouldn't have done in the scenario. So it cuts down a lot of your scribing if you're trying to. I've had people try to write down everything the candidate said or did in here, and it's just not designed that way. You don't need to write anything down unless it's wrong. Now the dynamic cardiology, there it is. It's just back to kind of the 1-0s. When you get down to the rhythm interpretation, did they identify it correctly, yes or no? Did they manage the rhythm, yes or no? Did they know to change in the rhythm, yes or no? So a little bit easier than the static, but both pretty good stations. Let's see. Yeah. The random skills, the issues I've seen with those is having a patient, and this is more of an issue with the training program, anything. Patients need to be average adult height and weight, so the mobilization equipment works them right. The seated mobilization I talked about already, not getting hung up on which strap goes where and which time it's attached, just that the body, the device has to be secured to the body for the head to mobilize. And I can probably take this out now. This is a big thing several years ago when we started using the tourniquet again, hot and heavy. I think everybody's getting used to that now. It used to, for some of them as old as I am, the tourniquet was an evil, horrible thing that you would never use, and now it's like, oh yeah, put that on now. I just got a message, and I missed it to just now, saying that every once in a while my mic is cutting out. Is anybody else having problems, or is that a site-specific issue?
You're fine over here, Joe.
Okay.
We're good at DMAC, Joe.
All right.
Good at Hawk.
We're good at Indian Hills, Belmont.
All right. Okay. Yeah, it must be a site-specific one there, Evan. Sorry. So there's a bunch of materials you're going to be dealing with as an evaluator also. And these are really important things, and there's some very important things you need to do with them. There are instructions for you, the evaluator. And in fact, the proctor is going to go off on a big speech before you get started talking about the test and what you need to do as an evaluator. Pay attention to that stuff every time, no matter how often you do it. I used to do these tests once a month, all year long for years and years, and there'll still be things sometimes I need to be reminded of. Very few of us are doing enough of these evaluations that we are experts in it. We need to be reminded and just have it self-refreshed. I urge you, pay attention to that information just to make sure you don't miss something. Likewise, there's instructions for your assistants. In some tests, in some of the exams, you give that to the assistants to read. In some exams, you have to read it to the assistants. Please make sure you go through that. Again, we're trying to be consistent with every test. Make sure your assistants and your patients know what they are expected of. I've talked about your equipment list already, making sure you have that taken care of and you know which equipment you need to have and only the equipment you need to have, and you have all the equipment you need to have. Really important. You have the scenario, if there's a scenario for your station. You need to keep that secure. Bad things happen if that scenario gets loose and out and about during the test day. There's a good chance your test is going to be shut down or is going to be told to go home, and some people's tests may be invalidated and they may be told that doesn't count. That will not make you a very popular evaluator at all. So keep that secure. It should be either with you or the proctor. If you go to the bathroom, give it to the proctor or take it to the bathroom with you, just remembering that if you're taking the bathroom with you, somebody else is probably taking the bathroom too, so please wash your hands and don't lick the test materials. You also have dispatch information that you'll read off to the student or the candidate before they start. Make sure you read that, and this gets tedious, I know. When you evaluated 14, 15 people in a day and you're reading the same material for the 14th or 15th time in the day, you want to start taking shortcuts and paraphrasing, but remember, it's the candidate's first time. And the candidate needs to hear it just like the very first candidate did. It needs to be done consistent for everybody. And this is probably the part that would always drive me nuts. I got so tired of hearing myself say the same things over and over again, but it's very important you read those instructions verbatim to the candidate. And then your evaluation forms, the things you'll be documenting on. Once you get that handed to you, like I said, those are your responsibility. You need to keep track of those. They have to return to the proctor. You cannot make copies, distribute the scenarios, any of that stuff, other than the evaluation tool itself. Those are all open to being copied and shared. Okay, that's my summary, except I want to go back and hit one more thing because I've said it twice, and I think I need to say it a third time to make it really important. Always, please be aware of conflict of interest. Don't put yourself in a bad spot there. If you're an instructor, don't evaluate your students. If you have some sort of relationship or want to have a relationship with a candidate, please don't evaluate those people. If you work with them, if you're a supervisor, you just don't want to put yourself in that spot. That's probably been a couple of the bigger investigation issues I've had in the past with related to evaluation or related to practicals have been conflicts of interest issues that have come up. Just don't put yourself in that spot. Otherwise, does anybody have any questions about anything with this?
Joe, we've got a question here at DMAC.
Yes.
So just backing up to static cardiology, I was just thinking, you told us to only write down if they do something incorrectly. So if during the process you're sitting there writing, do these students know that you're only writing down incorrect stuff?
If they looked at the evaluation tool, they do.
Okay, so would that, do you think that's something that we should maybe clarify that it's something maybe we shouldn't be doing during the exam, or wait till at the end of the exam to write stuff down so that it doesn't make them nervous? Or do you think we shouldn't maybe focus on that at all?
Well, it's going to depend on how you feel comfortable as an evaluator. My fear would always be that I get to the end, I'm not going to remember what it was I needed to write down. So I mean, it's not a perfect thing, but it may be something you got to do.
Okay.
I just wouldn't make it flamboyant. Don't put a lot of flair to it as you're writing it down, so draw attention to it.
Okay, thank you very much.
Sure thing. Had another question come in chat here. Somebody asked, how will we find out we can start evaluating? You need to talk to your training program on that and find out what they want you to do before you can start evaluating. Hopefully, again, they're going to give you some sort of training before putting you in that room to evaluate people. So check with your training program. Any other questions?
Joe, a question here in Council Bluffs. do we have a concrete date that those new testing criteria will be implemented?
No, only thing they had in the newsletter today was fall of 2016.
Okay.
And again, Gabe, when I talked to him today, I think they wanted to get that information out, but they don't have all the details in place yet.
Okay, thanks.
Somebody sent a message, we'll receive some sort of confirmation that we have gone through this workshop. The way the process works for the endorsement is your training program requests an endorsement, and then we'll approve that, and that endorsement will show up when you log in the system registry. When you pull your certification information, you'll be able to see the evaluator endorsement there. But again, that falls back to your training program making the request for the endorsement, and then I'll approve it as soon as it pops up on my screen. Any other questions out there? Well, just in case someone comes up, whoop, I think I just had one pop. I have a question about nursing being an evaluator. That's a training program issue. We don't have a way to give them the evaluator endorsement. They'll show up on our website, so each training program holds that information when that evaluator attended the workshop, and they maintain that record when it's a nurse. We allow nurses, PAs, and physicians to function as evaluators, and the nurses, PAs, and physicians don't show up on our system registry in any fashion. So if there's any training programs that have that question on that, give me a call, and we'll kind of talk through that. Well, I'm waiting to see if any more questions come up. We'll say a huge thank you for all you for doing this. We have a lot of evaluators out there that hold the endorsement, but we don't have as many that actually will show up the days of the test. They are long days. They are a lot of work, but it's a really important part of this whole profession, making sure that we've evaluated people. We're comfortable with them functioning in the pre-hospital environment with the skills that we've trained them on, and I just can't give you enough thanks for doing this, being an evaluator. It's really important to the Bureau of EMS, and it really helps the training programs out both.
You mean the Bureau of Emergency and Trauma Services?
Yeah, whatever we are now. Can't just say the Bureau. It's important to the Bureau.
That's a good thing.
I'm an old dog. I'm not good with new tricks. I'm about hit 13 years here, so it's hard for me to shift now. All right, folks, I'm not seeing more questions. I'm not hearing anybody say anything, so I'm going to hang out here for a while, but that was pretty much it for me. But while I pack up, I'll leave the mic on, and I'll leave this on unless Sherry kicks me off. If someone comes up with something, feel free to buzz in.